Hello, I'm Dr. Mike Lozano. I'm an Associate Director in the Office of the Medical Director and MD10 on the radio. Today I'd like to use a clinical case drawn from our system to illustrate points that will help you in the care of patients with cardiac arrhythmia. So we've got an 82-year-old male with chest pain and shortness of breath. He's in a private home and the scene is safe. Big piece of info here is that he just got over about a CHF that was serious enough that he was hospitalized. He has chest pain that started half an hour ago. He also has shortness of breath. May be confused. We now have three major body systems involved: cardiac, respiratory, and neuro. Let's look at the primary assessment. Sounds to me like he checks the box for being sick, doesn't he? And that's before we're even looking at his vital signs. The physical exam had some positive findings and some worrisome findings as well. Here's the money shot for this case: the rhythm strip. What we have here is a Y-complex tachycardia with apparently a one-to-one correspondence of P waves to the QRS complex. In other words, ventricular tachycardia. So what do we know so far? We are faced with an elderly male with a dysfunctional heart. We infer that from the history of CHF, necessitating diuretics and antianginals. The monitor is showing a Y-complex tachycardia. What does that say in and of itself? It's an infranodal rhythm. It's fast. Since systole is relatively fixed for a given patient, a fast heart rate cuts down on the amount of diastole time available. Less diastole time means less ventricular filling. That is the same thing as less preload. So less preload means less cardiac output. In this case, the decreased stroke volume overshadows the increased heart rate to cause a net decrease in cardiac output. We see this manifested by the low blood pressure, cold clammy skin, and confusion. In our case, the proximate cause of the immediate life threat is a cardiac arrhythmia. Thus, this is a primary arrhythmia. With a primary arrhythmia, we focus on our efforts on correcting the arrhythmia. If the arrhythmia is part of the body's response to an underlying disease process, then it's considered a secondary arrhythmia. With a secondary arrhythmia, we focus on efforts on correcting the underlying process. Here are some examples that I put together illustrating the different presentations of a primary versus secondary arrhythmia. To me, the key in differentiating these is the immediate life threat or not. The 30-year-old could have a thyroid problem driving the SVT, but in this case, the SVT is impacting the blood pressure, so we are pushed to address it. Generally, in secondary arrhythmias, we in the hospital will be working on the underlying cause. Knowing that it's a primary arrhythmia means that we will address it directly. What makes for stable versus unstable arrhythmia? Cardiovascular stability is part of the equation. Is the patient on the verge of cardiac arrest or not? Cardiac output plays into it as well. Is the cardiac output sufficient to perfuse the brain and other vital organs? Perfusion status is something that we indirectly infer from the physical exam. Is the patient in shock or not? Time course is also important. In terms of time course, is it sustained or not sustained? This applies both to SVT and VT. You can have scattered PVCs, but not impact on cardiac output, or have only 2 or 3 a minute. In that case, it's less important. Acute versus chronic is another question to ask. They could be an MAT or AFib and have been in that for days to weeks. That would argue for less of a need for immediate intervention. Back to our case. We had a primary arrhythmia and an unstable patient who needed immediate intervention. He received synchronized cardioversion with 100 joules. Is that what you were thinking? The result is displayed here. The patient converted to a sinus rhythm at 85. His BP improved, skin dried up, and mentation improved. Those rhythm strip ST segments look a little troubling. What's the next step? Yes, a 12-lead EKG. We see some lateral ischemia with flip T waves in 1 and AVL, as well as what appears to be ST elevation in V5 and V6. So here's our take-home points. Arrhythmias can be primary or secondary. Primary ones are the proximate cause to the patient's condition. Secondary arrhythmias are part of the body's response to an underlying process. Arrhythmias can also be classified as stable or unstable. Unstable means that there's an immediate life threat. Stable means that you have some time to think and sort things out. Thank you for tuning in, and stay safe out there. This is MD10. We're clear.